know that we're going to record this. So today's virtual event is an RHC update. It's moving beyond the new payment caps towards strategy. And I'm sure most of all of you recognize the presenter, Ralph Llewellyn. Ralph is a partner at Eide Bailly. He's in charge of critical access hospitals, and he has a great passion for rural healthcare and really has been a true partner working with MCRH in the state of Michigan over the years. I'm going to assist with question and answers, so I'll be monitoring the chat function if you would rather use that than just speaking up. I'm sure Ralph will ask questions along the way, as he always does, and ask for feedback. So please feel free to speak up, and we welcome everybody to use their camera function as well. So I'm going to go ahead and turn things over to Ralph.
All right. Thank you. I greatly appreciate the opportunity to get to visit with you guys today on a topic that is, I think, definitely an important one that people need to be thinking about. It's actually the second time I've been presenting the same topic today. So I've had a couple of different groups across the country that are definitely looking at this issue. So we'll dig into that and kind of get into the whole conversation. So when we look at this whole topic about the RHCs, the biggest thing that we know I've been noticing is that, since December, we've really been just seeing a lot of conversation about the timing and the financial impact, which are really, really important. We know we need to understand those things. There's still some unknowns there. We'll talk about a few of those here. But what we've noticed so far is there's been a gap, I think, out there as far as talking about, well, what does this mean from a strategy? And how might our operations change? How might there be reporting changes? Things that we should be considering that maybe weren't as important before in the past. So what we're going to explore is a little bit about the caps, but then we're going to try to spend more of our time about strategies, operations, reporting. That's probably where we're going to get the majority of any questions, Q&A going, discussion going in that area, if it's like other presentations I've done on this exact topic. So let's talk about the objectives, confirm the understanding of the per visit caps. We're going to talk about that. Then explore operational changes that might need to be considered, as well as discussing some cost report strategies for RHCs, just because of the changes. I think the most important piece on those last two bullets is really understanding that each situation is different. As I've been talking to providers about strategy and how they might want to look at operating different, reporting different, et cetera. The one thing I find is it's like hospitals, they're all different. So what works for one doesn't work for another one necessarily, although the same exact thing might work from one to the next. So you really need to make sure that as we explore the things that we're talking about today, make sure you understand how it's going to impact your facility rather than how it might impact somebody else's, because ultimately your facility is the facility that you need to be watching for. So let's talk a little bit about the payment changes, the background, kind of what's going on there. December 27th, we all got this big surprise that no one really knew that was going to hit us this fast. We get this increased payment limit for freestanding RHCs and provider-based RHCs with more than 50 beds. That's the plus side. I mean, when you think about that piece of it, a lot of the people that are probably on the call here have provider-based RHCs. We look at it as that there's this downside, and that's all we see. Here, if you're a freestanding entity, this is where they're actually going to see some improvement in their reimbursement. I think any of us that have been involved in RHCs over the last 20, 30 years can tell you that is one area where the payment methodology has really stagnated, really fell behind the times, And so effective 4/1 of 2021, there's an increase in their payment rate. And individuals that don't care for the rule in total, at least the majority of them will say this is probably a positive thing for several of the operators out there. It makes some sense. So increased rates starting in 2028. After 2028, it's going to be a slower increase. It'll basically be the Medicare Economic Index, but there'll still be some increases that'll continue on after that. So let's look at what happens here. And so you look at the rate that was in effect as of January 1st. So January 1st, the effective rate 87.52. That rate bumps up, you know, a percent or two every year. Basically, you know, not too much increase in that going on. But all of a sudden, April 1st, it bumps to 110, 113, 126, you know, all the way up to 190 in 2028. So rather than getting a couple percent increases each year, freestandings and those over 50 beds are going to start out getting about 13% a year. As you look at 2022, it decreases a little bit because it's going up about $13 every year. But even in 2028, that increase is about 6.7%. So this side of the whole process definitely provides some opportunity, maybe some challenges for some facilities, but definitely provides for those that are subject to the cap in the past. This has definitely been something that is being looked at as being a good news item. So let's talk next about the provider-based RHCs that are attached to a hospital less than 50 beds. So now we're going to get this new cost per visit that is for grandfathered. So hopefully the majority of the people that we have on the call are at least an entity that did fall into that scenario of being a grandfathered facility. And so the first thing we need to know is, what does grandfathering mean? And so to be grandfathered, as of December 31st of last year, you had to be provider-based to a hospital that was less than 50 beds, continue to be less than 50 beds, and have one of the following two items occur for you to meet the criteria of grandfather. That is, as of December 31st, 2020, you were enrolled in Medicare. Or the piece that came in a little later, which was good, is you at least had submitted an application for enrollment in the Medicare that was received no later than December 31, 2020. And that was really important because, interestingly, as all of this starts to happen, for the last 6 to 8, 9 months, we'd seen a pretty big uptick in the number of facilities that were jumping into provider-based RHCs. And so we had numerous that were actually in the process, hadn't been licensed, weren't going to be able to get surveyed in time for the December 31st, but they had plans in place well before any legislation came out. And so this was an important piece to at least have a grandfathering component. It made sense. Initially, we weren't sure we were going to get that, but it tied into place with some of the same things we've seen with other rules in the past, like the change they made in January of 2008 for offsite provider-based clinics. At least they did a grandfathering if you were already in the process of building. So there is a grandfathering component there. If you don't meet that, then you move into this other group of being new. And if you're new, you're basically going to be treated the exact same way as a freestanding RHC or a provider based with the greater than 50 beds. So you're going to start out at $100 on 4/1. You're going to go next year to 113 and then 26, 39, etc., all the way up to the 190. So that gets us kind of what's going on there. Let's just take a couple seconds here and talk about how are they going to come up with that rate. And so what they're going to do is they're going to basically look at your rate that was established for 2020. And they're going to, for 2021, they're going to increase that by the Medicare Economic Index, which is 1.4%. And keep track of that number, because that's, you know, the overall rate we've been seeing is 1 to 2. And so you got to think about that's kind of increases you're probably going to see in the future. You may see a higher one next year because of some of the inflationary factors we've seen, but I don't think it's going to be substantially higher than that. So they're going to look at your 2020 rate, update it with the 1.4%, and then look at the per limit, the payment limit per visit that is applicable to the freestandings, and they're going to pay you the greater of. That is if you are a grandfather. Subsequent years, they're going to basically take your prior year, your 2021, and they'll look at adding the MEI. So that's where you're going to get that 1 or 2%. And then again, they'll compare it to the payment limit, because for some entities, while they may be subject to their grandfathered cap today, let's say I have a facility that's getting $140, $150 a visit. Well, it's possible that in some of the later years that the MEI on that cap won't grow as fast as the cap does when it's going $13 a year. And eventually they might just become subject to the overall cap that's applied to all new facilities. So there's going to be a lot of, from what we can see, there's going to be a lot of monitoring and making sure that the MAC and the facilities, the organizations, are keeping track of what cap should be applicable, and it's actually being applied in that manner. There's going to be a lot of moving parts in the implementation of this going forward. So as we look at an example here, we have an all-inclusive rate of $225 in 2020. They add the 1.4%. You get a new rate of $228.15. If that's great, if their cost per visit is greater than that, that's all they're going to get. So if their rate went to $230, $240, $250, they're still going to get $228.15. If it went less than that, and say they improved some costing, or they improve some productivity, the cost per visit drops down, and say it gets down to $195, they're going to get the $195. So there's only downside to this piece. There isn't a potential upside to you. You don't get it, you're not going to get that back later. That's what's going to happen in that rate. So let's talk. Yep.
Can you go back to that last slide real quick?
Yep.
So in this scenario, in year 22, if you go down to 195 because you were at the lesser of your 4% increase, the following year is your max 225 times 4%, or is it 195 times 4%?
Well, the next year would be the 228.15 plus whatever percent.
Right, but if you were the lesser of the two,
right, your cap is still the same.
Your cap is always going to be 2020's cost report all-inclusive rate.
In moving forward, we have not seen anything that would indicate that if you drop your cost, all of a sudden that's your new grandfathered cap.
Okay.
Now that would be something new. That's a great question, because it's always on how they implement it. And I've been doing healthcare. On Monday, it'll be 30 years. The one thing I have learned is that what you expect to happen isn't what always happens. So that's something to watch, but I've not seen anything that would indicate that otherwise. This would be consistent in the model we're showing you here, consistent with how they apply the caps to the over 50 and everything else. Just because your cost came down lower doesn't mean you get a lower cap in the future. Your cap is still following that overall cap. All right, so let's talk about if establishing one. So you're going to establish this cap based on the 2020, as we indicated. It's the using that cost report period. The issue is that so you have a filed cost report, a finalized or a settled one. What happens if that changes? Are they going to go back and update that cap? Those are some things that we're still trying to get specific answers. It would seem like the finalized cost is the one that should be used, but we want to get something that we know is definitive and applied on a consistent basis, so they're not picking whichever one they want to use based on their advantage. We definitely want to figure that out. The other thing is that when you think about the rates that you're getting paid in 2020, a lot of times they were set up based on 2019. And so there's a lot of confusion, are they going to make sure that they're actually using the 2020 cost report settled? We're still watching that. We believe it's all going to be on 2020 and final, but there is nothing in writing that we would say makes us feel totally comfortable. The new provider-based clinics. So this is where it really gets kind of crazy. So if you are a new provider-based clinic, it's possible that you will not have a 2020 rate or a 2020 cost report, because you could have been one of them that has your paperwork in as of December 31st, 2020, but maybe it's going to be a while before they get out and survey and everything else. As an example, I had a call yesterday with the provider. They had their survey finally on October 7th. So their earliest date for their tie-in for being able to bill as an RHC will be October 7th of 2021. Now, to compound this a little bit, they are a September 30th year end. So as they go to file their cost report for September 30th of 2020, they're not going to have an RHC rate yet. their first actual cost report with a RHC on it is going to be their 9/30/2022 report that is not due until February 28th of 2023. And so how are we going to come up with rates? Because if you've had any of these, that you're a provider that's got one of these new RHCs, one thing you'll notice is that when they send out their rates and they set your initial rate, they're basically, the max we've been seeing are all setting it at $100. And it's like, well, we'll get it settled later. And so there's a couple things there. One is we're working with the max to make sure that they are at least acknowledging that these facilities are grandfathered facilities. So we fight that fight now rather than a year or two down the road when they're trying to get some settlements going on. And then the other part is we're starting to inquire and try to push to actually allow you to use like a budgeted cost report to come up and say, okay, this is what we anticipate this is going to come out to on a cost per visit. That's what we want to get set as our interim rate. Kind of the way they do when they do interim rates for the critical access hospital. They ask you for some data. They come up with what they anticipate that rate's going to be. Even if we can't get 100% of that, if we can get part of that, we're at least alleviating some potential cash flow challenges that we don't want to have to deal with. So basically, they'll set that up on 2021. And then going forward, they'll establish a rate with the MEI, compare that to the payment limits, and you'll get the higher of the two. So that kind of gets us through kind of the piece that I think most people can say they've heard a lot of conversations around. What I want to get into more and spend the majority of the time on and allow questions and answer time for is on the operational considerations. Because to me, that's the piece we need to be starting to think about. So a couple of things here. When you think about freestandings, we think that freestandings are actually going to see less challenges as the caps increase. And that's going to be because if you go out and look at freestanding clinics versus provider-based clinics, there is a big gap between what the cost per visit limits are. Having been paid $87 a visit, when they start getting paid 100 or 113, 126, all they're going to be seeing is some positive pieces there, which is true. One of the things we do think they're going to see at some point in time is some increased scrutiny. And it's going to be scrutiny around the cost report submissions, because at some point, when you've got a lot of them that you deal with, I was just working with one state, a lot of their freestandings are probably in that, they're probably anywhere from upper 90s to about 110, 100 and a quarter. Well, it's not going to take very long to where that cap is actually higher than what their cost per visit is. And so, while in the past, if a Medicare auditor spent a lot of time auditing an RHC, it probably was going to have little to no impact because they were so far over the limits. There's going to be a potential, if they're claiming costs that they shouldn't or missing some things, that they could actually be reporting a cost that's higher than what it actually is. And now CMS is going to have a reason to MAC to actually go in and audit these and look at that a little bit deeper. So I do think we're going to see some increased scrutiny on the freestandings. On the provider-based, that's where we really think that we're going to see these greater challenges. As I mentioned already, the Medicare Economic Index, increasing at a 1 to 2% historically, but your costs are typically a lot faster than that. So my question to everybody is how many of you have experienced only 1 to 2% growth in costs? Because that's what we're going to be subject to on that cap going forward. And in addition, how many of you are in older buildings, older plants, et cetera, that are looking at some point to having to replenish the building, the operations? So if you're in an aging facility, your cap in 2020 is based off of a fully depreciated or fully depreciated plant. All of a sudden, you're moving into a brand new one. All those new costs that are above and beyond that cap, they're going to be on you. You're not going to have somebody cost sharing in that scenario. So we think it's just going to be a big difference in how provider-based RHCs are going to have to think about things as they look at additions and changes within their programs. So managing the new challenges. Let's talk about some things that we believe we're going to start to see. I really think we're going to start to see, and we're starting to hear a little bit of it already, an increase on the focus on the direct expenses related to the RHC operations. And I don't want to I don't want it to make it sound like people were not paying attention to that in the past. But we do know that it probably wasn't as critical from the aspect that if they did miss some things or let some things go, as the cost grew, at least they had somebody sharing in those costs. Here, you're not necessarily going to have that. Some of the other things, that we're going to be seeing people look at is what do they do in the RHC versus what they don't do in the RHC. And I think what we're going to find is as time goes on and there potentially becomes a gap, and I'm going to talk about that gap in a second, there becomes more of a gap between their actual cost and the cost per visit. There is going to be at least a push for conversation around what are our high cost services, and is it going to be better to move them somewhere else? So, a couple things, you have to look at there is how does that affect patient flow, patient access, satisfaction, as well as reimbursement. And having been a CFO, I like to say reimbursement's the driver, but we all know better. We got to make sure it works from an organizational perspective. So a couple things that I've seen conversations around, nurse-only visits where they come in and there isn't a medically necessary face-to-face. These could be just injections, things like that. I have some RHCs that still do those in their RHC. I have some that have said, no, I'm not doing it there because I don't get paid separately for it. It goes into the cost per visit limit or the cost per visit, but now there's this limit. Will that cause people to say, I can't do that in here anymore because I've got this limit? In effect, I'm losing that dollar and cent. Am I going to change that? Maybe high cost procedures. I have some that will do some procedures, some lesion removals, things like that. I'm already hearing them say, I might have to look at, can I feasibly continue to do that? Do I have to start looking at doing that differently? Even had a conversation today about, somebody who's got specialty providers. Specialty providers sometimes can drive up that cost per visit because they're a higher comp, less visits per provider. Will it make sense at some point for them to look at a different model? Going back to, is a provider-based clinic make more sense for those specialists in the RHC if you have separate distinct space that you can set them up in, or do you move into some other hospital-based clinic kind of model that might make more sense in the totality of total reimbursement? So I have some facilities that do a ton of procedures in their RHC and nurse only. I have some that do absolutely none. And then there's this blend in the middle. And I think we're going to start to see more and more facilities at least having the questions and conversations about, should we be taking and moving some things out of here because of just the overall ability and feasibility of being able to handle the programming and the costs and everything else. So definitely think we're going to start to see some changes in that arena. Over time, we expect that this gap is going to get created. Year one at 1.4% or whatever, yeah, there might be a gap, there might not be a gap, depending on how well you were able to control cost volumes and everything else. But when we think about what's going on out there, where you've got, let's say your costs are going up 5% and the Medicare Economic Index is going up 2%. Well, in 1 year, that's probably 3%. You got a 3% difference. 3% is not the end of the world, but you guys all operate on small margins. 3% adds up. But that's in 1 year. In 5 years, you're talking almost 16% if that continues. If you go out 10 years, you're talking more like 34, 35% difference in reimbursement. At that point, without anything changing, organizations are going to be forced into having conversations that maybe they haven't had in the past and really don't want to have, but from a feasibility perspective, are going to be very, very important conversations as this gap continues to go. Even if you've been a facility that I was thinking about this last night, if you've been a facility that hasn't been hit by the productivity standards, but let's say you just become less productive, so your total number of visits go down, you're not hit by the productivity standard, but because the visits go down, the cost per visit goes up because you're spreading that fixed over a smaller base, you could actually end up losing dollars from that. So even if you controlled all your costs, if your visits drop, you could end up getting hit from that perspective and having dollars being left on the table. So there's going to be all kinds of things that people are going to have to monitor a little differently than what they have in the past. In addition to yep. Was there a question? Okay. In addition to direct costs, we anticipate organizations will begin to explore just how do they staff these clinics. We do see some big differences between the mix of PAs, NPs, and CNMs versus providers, between clinics. And I would say you see a real big difference when you look at freestanding versus provider-based. When I do analysis on freestanding RHCs, you will notice that they are oftentimes, 60, 70, 80, 90% operated by a PA, NP, or a CNM. If they're provider-based, they might be 40%, 30%, depending on the model. Some are a lot higher, but there's this big variation. As that gap grows, we believe that we're going to start to see a push for a conversation of, do we have the right mix? Can we afford the mix we have? Because by bringing in and putting a PA, NP, or a clinical nurse midwife in place versus a physician when you need to replace a provider, you might be able to help drive down your cost per visit, help control where you're at on your cost per visit compared to that cap. Now, it's not just a financial consideration, so I want to be careful there. There's more to it. Obviously there's the clinical pieces, the operational, got to make sure you're taking care of the patient needs, all of those things. But I think we're definitely going to see providers having to look at their long-term strategy and try to figure out, how do I get, as I look at lower costs, how do I better utilize the mid-levels, the APPs, whenever possible. It's just going to be something that's going to be forced upon providers to look at in that long run. All right, let's move to some cost report considerations. I think the big piece here is that, a lot of times when we talk about cost reports, we're talking about the CAH side of things just because of the total cost, total volumes. There's some conversation going on in this area, but not to the level that I think we are going to see as we continue to move forward. And so a couple of things here to keep in mind. The strategies of the past may not be the strategies of the future. It doesn't mean it was a bad strategy in the past. It's just it's a strategy that's time has come and gone. And now we got to look at, how do we fix this? How do we make this better? It is going to require analysis. Kind of goes back to some of the stuff I said earlier about every facility is different. Each situation is different. So you really want to understand what makes sense for your organization. How does that work best? And then there's going to be requests. If you're going to change your allocation methodologies, your reporting methodologies, there is a requirement to send in your request and get approval. To remind everybody, that's a 90 days prior to the end of the cost report period for which you want it to apply to. So it's one of those few areas that you actually can be well into a year before you submit your request. It can be valid all the way back to the beginning, as long as you have all of the detailed data information to use that statistic you're asking for. So we're definitely going to see some things going on in this arena. So a couple of areas here that we want to talk about. Let's first start with the understanding and confirming the overall accuracy on your cost reports for the non-RHC patient care cost assignments, as well as reclassifications. So a couple of things when we talk about non-RHC. The first thing that comes to mind are the ancillaries, the diagnostics. So if you do lab, radiology, and EKG, they're considered a non-RHC service. Those costs are supposed to be reclassed out of the RHC and over into the corresponding hospital department, and you will get cost-based reimbursement for those services out of that side of the model. One of the challenges we have as we work with providers in the preparation of the cost report is always capturing all of that information. I believe that because of the fact that you're usually using a lot of shared staff and such, it's really difficult to really come up with what the true cost is. So there is a real risk that historically there have been costs left in the RHC that shouldn't have been there. It should have been over in the diagnostic area. Now, we have a hard time sometimes getting people excited about moving the cost because it's basically moving it from one cost department to another cost department. Although I would say it's still a compliance area, it should have been in the right area. But as you start to creep up over caps, anything that you inappropriately leave in the RHC is going to be money that you're not going to get anything on. And even historically, when we think about how we get paid, it's important to remember that we never got 100% cost reimbursement out of the RHC. We get 80% of our cost. We get 20% of our charge. So every dollar we leave in the RHC, we're going to get cost based at 80%. If it was in the hospital side, we get it at 100%. Now we got to look at the Medicare utilizations and everything, but that's a pretty big gap in there. So really, if you have a little bit of homework you want to be assigned out of this here, it's going to be going back and looking at going forward. Can I better capture that data, get that cost over to the hospital side to help manage my cost per visit by being more accurate in my cost allocations. We also got to make sure that we've got the chronic care management, the telehealth. That's more of a compliance piece because you got to have your costs in there because you're getting paid outside of the RHC. It's a fee schedule. Emergency room availability, I think, is an opportunity for providers to really look at. You know, a lot of times, and every facility again is different, but a lot of times our providers in the clinic are the ones that are providing our ER call. And the contracts aren't always clear as to how much cost is for clinic versus how much is for ER. And so we don't always get costs out of the RHC that we probably could or should and get it into the ER. And so we are having providers that are starting to look deeper at their contracts to say, how should I better break this out so that I make sure I have those costs assigned so I keep the costs where they belong and I get reimbursed better. So I'm gonna have better accuracy and better documentation, and I'm gonna get hopefully reimbursed better in total in the long run. Hospital administrative duties is another thing. If you have any of your providers that are doing any directorships, any other administrative functions in the hospital side, you know, we want to know that in the contracts, be able to get that cost, move that out of the RHC and get it so it matches up with what area of the hospital is getting the benefit for that programming. So definitely a lot of things to look at here. It's been things that I think people have looked at a little bit in the past, but definitely with the caps coming in, it's something that we need to make sure that people are taking a deeper dive. And so whatever you can pick up in the first year, you just got to remember that this is going to be something, the more you can control that cost, it's something you're going to get a benefit for every year going forward. Let's talk a little bit about some offsets. You know, understanding what costs need to be offset, making sure that we're just offsetting the appropriate amounts of things for inpatient, outpatient services. Others, these might actually be reclasses, things like if the clinic is doing their own registration and you're allocating hospital registration out of A and G to everywhere, we got to make sure we're doing a reclass of those administrative costs out of the clinic and into the hospital side. I see a lot of facilities that are doing that fairly well, but I don't see that consistent and all the time, but definitely some things that we want to look at there. At the end of the day, all of this is going to probably drive a need to really go back and look at your provider compensation agreement. You know, can you get through the details saying how much cost goes to each area so that at the end of the day, I can allocate my costs appropriately and have the justifying documentation behind it. Vaccinations. This is an interesting one. This really came to light to me probably in the last 2 years, even before the caps came out. I've been working with a couple of organizations, and we were looking at some various cost indicators in RHCs. And in the area of vaccinations, we found a significant variation in the reported cost per vaccination. And, you know, some of it can make a little bit of sense because of volumes and things like that there. But I've seen vaccinations, influenza ones, as low as 20 some bucks, and I've seen them as high as, you know, 200 bucks. I know there's some different costs of vaccinations and stuff like that, but that doesn't always explain it. I think historically, when you get to that part of the cost report, and you're completing that for your preparer, you know, it's just one of those things, you take some estimates and come up with it. I think that there's some potential that we're underclaiming the costs that are truly vaccination costs. And so in the past, while you say you got cost on the RHC or cost on the vaccination, I think that we got to look at this a little differently. First of all, remembering that we need to understand the impact of cost in the RHC versus vaccination. It's in the RHC, Medicare is going to give us 80 cents on the dollar if we're not over the cap. On the vaccination side, it's dollar for dollar because it's 100%. And we got to look at, you know, the Medicare utilization between the types of services. So overall, if you can get more accurate and identify more costs that should be in the vaccination versus in the RHC, there is going to be a benefit. Now, you can't just make up the numbers, obviously. It's going to have to be something that you truly have the documentation behind to be able to support all the costs that you are claiming in that area. So definitely an area that I think we're going to see some additional focus. If you haven't done that and looked at it, definitely something I would highly recommend. Just go back to worksheet M-4 of your cost report. It'll come up with your cost per vaccination. Look at that from just a reasonableness, a sanity perspective, and say, does that make sense? If it doesn't, it's time to start digging deeper. Accuracy of reported visits. This is one that, you know, I think at least there's probably two things here that we want to make sure. One is if you're freestanding, it's probably going to impact them more, because I think freestandings, because they haven't been subject, they've been so far over the cost per visit limits, they haven't always done as good a job at coming up with what their total visits are. Sometimes they're including nurse only and stuff like that. In the future, as their caps go up and their actual cost per visit is lower than the cap, if they're overstating their visits, they're going to get reimbursed less. So I think they're going to be focusing a lot more on that to make sure that they're not including any of these nurse only or non-RHC type services in their visit counts. I think as a provider, if I was in your shoes, the one thing I'd want to make sure I've done is I'd probably go back and relook at my 2020 numbers and really scrub that hard to make sure that, you know, whoever gathered that statistic internally for visits did not include any nurse only visits or any other non-RHC such as inpatient, outpatient, telehealth, and chronic care management, because whatever they include in there, that is going to go into the calculation of your cost per visit. And if you overstated that number for some reason, and it's not uncommon for this to happen, but if you did overstate that number, it's going to understate what your cost per visit was, and that is going to be the base cap that you're going to have going forward. So there's some real possibility of risk there if you haven't really went back and just confirmed that what you have there was in fact accurate. And so something definitely I would highly recommend people think about looking at from that perspective. And this piece here on, you know, looking at just the total overhead allocation methodologies, this kind of reminds me of going back to 1997, 98, when we have critical access hospitals coming out. And the first thing we did is we went back and we looked at all of the B1 stats and how we allocated things to make sure that we picked the best methodologies. And best meaning the ones that we can document, get approved, and help us financially. And so the key here is, well, historically, if you allocated more costs to the RHC, you can say you were going to get more reimbursement because there was no limits. Now you're looking at any costs that are above and beyond that cap, they're not reimbursed. So this goes back to what you used in the past may not be what's right in the future, and we have to start re-looking at all of that. Again, you have to use approved methodologies, so we have to have something like that we have to deal with. The key here is that, again, that 90 days, getting that all in, but it's going to be all the analysis. And so I've put up here a couple of scenarios here of things that you might want to look at. Depreciation, you know, if you're over the limits, you know, if it's a separate building, have you fragmented your depreciation so you're just allocating RHC building costs to RHCs versus having it all aggregated with hospitals, because hospital square foot's a lot more expensive. You may be able to benefit from that kind of a change in methodology. I see a lot of people using MME, which is major movable equipment. They're allocating that based on square footage. Well, that applies a cost per square foot for movable equipment to the clinic equal to what they would send in the OR, med-surg, radiology, etc. It's an approved methodology, but maybe if you were to get approved to do actual, you'd find that your equipment cost per square foot's a lot less expensive in the RHC. You'd be able to justify pushing some costs over to the hospital side, the ancillary departments where they have higher Medicare utilization, cost-based reimbursement 100%. You know, you've got that scenario there to look at as an option. With that, I'd say I've ran into in the last couple of years more and more facilities that have been using the simplified cost finding methodology. That may not be in the best interest going forward because of things like this where MME has to be done on square footage. So a lot of different things to relook at. Administrative in general, what we're looking at there is, looking at the fragmenting of A and G into individual components. So rather than allocating it all of it to the various departments based on accumulated cost, we actually move it down into components and say, I'm going to allocate my IT costs based on terminals. I'm going to do my admitting based on revenues. But if I have admitting staff in the RHC, maybe I leave their costs there and they get their direct costs there, and the hospital gets the hospital admitting. And same with the billing office. We have separate groups there. It's just ways to step back and look at, are there different ways to skin the cat using approved methodologies that would get, at the end of the day, maybe more refined, more detailed allocations, but these allocations get costs where we can support that they really belong, but they also end up being in areas that we get better reimbursement dollars at the end of the day. Housekeeping, a lot of people are using square foot. The problem though is that applies square footage the same to every area. Not every area is cleaned the same amount of times or as often. You think about a clinic might get cleaned 5 days a week because they're open 5 days a week, where the hospital's 7 days a week. So if you went to time studies, would you be able to justify some shifts in time spent by directly assigning it through the allocation methodology of a time study to get that enhanced reimbursement by having better detail? I've even seen some facilities that are working on some weighted square footage things. In this area, what I would say is if you can dream the methodology, you might be able to get it approved. I've seen some requests over the years, and as we put them together, I said, we don't have a very good chance of them approving this. There's a lot of reasons why they might not want it to be allowed, and only to find out we get it approved. So don't be afraid to ask. The worst they can do is say no. Plant can be broken out into separate buildings if you have separate meters. Think about it. If a building's open more often, like a hospital, cost per square footage for heating, cooling, things like that might be a lot higher than it is on a clinic. So you might be able to look at some allocation methods that way. Time studies for the maintenance personnel might be a way to look at some things a little bit also. Although over time, I haven't seen as many entities benefit from a time study in that area, but definitely an opportunity. And et cetera. I put et cetera there because you just got to keep thinking outside the box. When I get in help providers in this area, I basically go and look at every GL department that shows up in every overhead department and try to figure out, is there a different way to allocate this? Is there something I can come up with a different basis that makes more sense? And each facility is going to be a lot different. Ultimately, the messaging here is that I really think every facility should, like they should every couple of years anyway with the CAH model, really consider a complete reevaluation of their overhead allocations because of the changes in these rules. There's definitely going to be some opportunities for some providers, not everybody, but definitely some providers. This brings us to the last little section I want to talk about, which is going to be some other considerations. And so what I did here is I basically pulled together some real life scenarios because we're getting calls all the time. And I think sometimes to help us think outside the box about what might we be able to do with this and make it work to our best ability is to understand things that people are talking about, thinking about. So I've got 3 of them here. We'll kind of walk through, and they're not the end of the line. I mean, there's going to always be more, but I have a couple of facilities that are looking at where they've got multiple RHCs. Maybe they got 2 RHCs in the community and they've kept it that way for a long time. They're actually starting to talk about, do we actually try to bring it in under one roof? And by doing that, when we combine the multiple, the surviving number that we would stay with would be the one with the highest cap. So if I have a high cap RHC and a low cap RHC, is there a benefit of moving the low cap RHC into the high cap RHC and blend those together? And now I've built some gap, or I have a good gap. I mean, my cost is actually below my limits. Or if I'm over the limits, does it help me at least help try to drill it down a little bit so I'm not as far over the limits? I see lots of conversations in that arena, and I think we're going to continue to see that. I actually have one facility that historically years ago, Medicare would make them have separate RHC licensures, even if they had different suites in the same building. And they've relaxed that a little bit, and you still have to meet some requirements, but you could actually have a couple different suites in the same building if you got it set up right. And so what they're looking at doing is, even in their own building, is to be able to stay in their same spaces. But since it's the same address with a different suite, updating all their 855s, getting all that done, and moving it all under one of those caps that's the highest. And so that's a little bit of a different scenario. And then they have, you know, some considerations of what they're going to do with those numbers, you know, those extra provider numbers that they're going to deal with. The next scenario, which is one that we're still working with legal counsel, CMS, and others on, is I have a facility that was looking at building a brand new plant for a clinic, and this clinic was going to be offsite, was not going to meet the requirements to be a provider-based clinic. So their options were going to be either to look at a freestanding model, or we were looking at the model of becoming a provider-based rural health clinic, which they would meet, or at least for most of the services. And along that whole process, as they're getting ready to break ground, is when these rules change. And so now they got a building that they are basically committed to, that they were looking to get cost per visit with no cap to being, I have a cap. So one of the things we looked at with them is this is an area that it's not densely populated, but there's a lot of smaller towns that are fairly close, 5-10 miles apart at times. One of their RHCs in a town that's like 5-8 miles away, whatever. And it's really small practice, that, you know, a couple days a week type of thing. And what they're going to look at doing, and we're working with legal on this, is to take that RHC and do a relocation. And the whole thing is that as we relocate, we're trying to get confirmation from CMS that they'll get to keep their grandfather number, because they're still grandfathered. They're not going to lose their number. They're moving within the same HIPSA. The HIPSA is still current. And so by doing that relocation, they'll be able to take that cost per visit in there, which is not as good as what they probably would have liked, but it's much better than a freestanding rate. They'll be able to use that new number and still continue to do this building, which they really needed to do. It's going to be a substantial asset to the organization. It was just not going to probably be a substantial asset if they were getting fee for service. That leaves them to decide what they're going to do with that current location. One of those things that they're talking about with that small little place is they may close it down because of lack of volume, or if there's a PR issue that they got to deal with, they may still keep it open periodically, but it'll be more of a freestanding model. And yes, they'll take a little hit on that there, but the benefit on the other side of the other entity is much more substantial, much more than makes up for what they'll lose on the current entity. Then we get to this last piece of, you know, the value of a grandfathered RHC license. And what I mean by that is, you know, that first scenario I talked about where they have 3 or 4 RHCs in their building and they're going to go down to 1, or they have, you know, the 2 RHCs in different buildings in town, they're going to move them into 1. The question is do you really let that RHC go away? Meaning, do you still somehow keep that the services being under that number to keep that number alive? And the reason being is that provider-based number that has a higher cap than the $100 or whatever, it has a value that you can never replace. So the one entity that had the 3 or 4, what they're looking at is they know that in their community, they're going to have to build some additional RHC locations, and it'll still be in their current HIPSA. They're going to keep a couple of those RHC numbers alive so that when they go to build that other offsite location, they'll do a relocation of their current clinic that might now only have a PA and part-time physician in it. They'll keep that so they can transfer it to the new location with the higher cap rather than they have to come in with the brand new caps. So totally different strategies than what we've been thinking about in the past. I've even heard people that, especially in the freestanding side, where they're saying the value of a grandfathered clinic, if you happen to get in before the HIPSA went away, but you still have it, Now with the caps going up, there may be some significant value to an investor to come in and say, hey, I want to buy that from you because I plan on expanding that clinic. I want to be able to get it, but I can't open my own RHC in your community because it's not a HIPS anymore. So that's going to be an interesting play. You may even see a little bit more if you're a provider-based clinic or a hospital. You may see some more competition on the freestanding side, because as the cost per visits go up, they may be in a situation where they can add services that they didn't do before, specialists, etc. So that's going to be kind of a little bit of a interesting play to see what happens going forward. And I think the key in all of this is I gave you some of these scenarios is to kind of say that, you know, there's endless possibilities. The more we talk about it, the more we look at different things, there are going to be more and more opportunities for providers to think about how can I still operate and do this as best as I can. Obviously playing under different rules than what I had to play for or play with in the past. So a couple things in summary, and then we'll open up for some questions. You know, first of all, understand the implications of the caps, know the timings, you know, understand the reimbursement implications, and then from there, start moving into the next step, which is you know, look at the operational challenges and opportunities. We know some of you are going to have to look at service line changes. Some are going to have to look at provider mix opportunities. Some are going to have to look at expenses. I mean, there's a lot of things there. And then finally, you know, the cost report is in one area that you don't necessarily have to cut costs and things like that. It's finding better methodologies. So focus some time on that. Look at the accuracy of the cost assignments, look at your contracts, look at the visit counts, do that whole relook of all the B1 stats, looking at the overhead allocations. You know, make sure you're picking the ones that make the most sense for your organization going forward, not the ones that were the best for the long term and in the past. So at the end of the day, it's really important to understand the caps and, you know, what's going on as far as timing. But I think the time is now that we have to start now looking at the strategies, because strategy takes time. And so you want to make sure that you've got time to implement and plan for the things that might make the most sense for your organization. Make sure that you keep yourself as much, you know, upside right versus upside down, and you know, keep that process continuing to move forward. So with that, I'll turn it over to questions. Anybody have questions or just, you know, specific scenarios that maybe they want to toss by, or questions they've had on things like this?
Ralph, I know that you noted that somebody it took them quite a long time to get surveyed. I mean, we had two that we applied the end of December, and we were surveyed by the end of March, so that we had, you know, at least we have a June 30th fiscal year, and so we at least had the opportunity now to get some current fiscal year numbers in to work the first year. But to have that so late, but those are still available. I mean, it's going to be based upon does it matter if it's a short fiscal year like that, like we're going to run into like a 3.5 month or fiscal year? Is that still going to set your number for your cost per visit?
What I would say on that one, Terry, is that there's nothing that says that it won't. But at the same time, there's nothing saying that, you know, that they won't go back and say it has to be your first full year. They haven't said that in anything I have seen to this point. You know, your comment about, you know, how long or how quickly it took you to get your survey in. There's a couple of factors that really drive that and make the variation. First of all, it's the state you're in, because in some states, the state survey teams are really quick about getting in and getting the surveys done. Other states, their budgets are really tight and new certifications fall to the bottom of the totem pole as far as priority goes. At that point, then you start looking at having to use some of these deeming entities. And so there's several good deeming entities that are out there, but there has been a huge growth in certifications, not just things that we were seeing prior to December 27th, but with these changes, you know, I can't tell you, in my 20 some years here And I would say I might get a call or two a year from a freestanding entity, RHC, or one that's looking to do it, because most of my facilities I deal with and most of the states I deal with in are really heavy, predominantly provider-based. Because of that cap, all of a sudden I'm getting calls from all over the country, California, the East Coast, Florida, you name it, from freestanding entities that are saying, with these caps growing the way they are, I want in. And so with that, those deeming entities, guess what? All of a sudden they're bogged because no one saw that coming. And so now that's kind of what's pushing some of those out, Terry. And I think we're going to see a little bit of that for the foreseeable future.
Okay, yeah, I mean, we were in the midst of doing 2 others, so we have 4 new ones in the last, in this last year. So we had 1 and now we have 5. So we had
Yep.
quite a big jump. So
Yeah, our team that helps people with survey prep and billing and all that there, this last year, it was amazing how many new RHCs there were across the country.
I agree with you in terms of your comments before about the M schedules were not paid that much attention to, and you didn't take that much time on them. Now it's going to become pretty important.
Yeah. I think it's a great thing to sit down with your staff and say, okay, I know in the past I caught you passing in the hall and asked you how long it took to do a vaccine. Now let's sit down and have a meeting about it. Let's talk about what are all the costs and all the time that's taken into doing a vaccine, and let's make sure that we capture it all.
Yeah. We've tended to keep away from putting specialists in the one RHC we had. Now we kept it to the other ones as well. So our costs are not in that, it's probably in the mid-range as far as the costs go. The one comment I think that, when you're going through it, when you have the history of you have your set rate, and you're showing like $228, I think. And then if all of a sudden your costs go down to 195, that doesn't become your new base. I think that's what you were going back and forth with Andrew Raymond on, right?
Yep. That's our understanding at this point in time at 1:58 Central Time on October 29th, from what I have read. But those are the things that we continue to watch. There's a final rule coming out. We should get more clarity with that soon too.
Okay.
All right. Any other questions from the group? If not, I do want to thank you again for the opportunity. I know that this focus has been on the caps, and they are really, really important. Now is the time to start looking at the strategy. This is something that might not hurt as much in year 1, but if we don't pay attention to the strategy by year 4 and 5, it could become extremely painful. It may be painful anyway. Now it's trying to figure out how do we alleviate as much as we possibly can.
There are no questions in the chat. I know you answered a couple of questions that I have received over the last couple of months, but doesn't appear we have any more questions, Ralph. I'm going to take a few minutes here to discuss a few things. We have our Critical Access Conference coming up on November 11th, so we hope to see as many of you there as possible. There's a CFO meeting at 9 a.m. on the 11th. I sent an email out yesterday on that. But just like to thank everybody for their time and their participation today. And a special thanks to Ralph. A lot of great thoughts and ideas there. If anybody did not receive the slides, it was in the updated email invite, but if you need slides, you can email me. And that's all I have. Ralph, thanks again very much.
All right, everyone have a great day and a great weekend.
Bye, everybody.
Thank you.
Thank you.